Okay, good day to you all. Hope this finds you all doing well. I am doing well myself, just FYI. So today we're going to talk about what we call the triple aim. So if you guessed that the triple aim was three things, then your brain is working well today. So those three things are quality, cost, and access. So these are the cornerstones of what we're trying to accomplish in our system: quality, cost, and access. But I want to start with just mentioning something that there was a study in 1999 by the Institute of Medicine estimating that between 44 and 98,000 people each year die due to medical errors in U.S. hospitals. All right, so this was a real eye-opener that in terms of quality, we tend to think of our system as having very high quality, and in many ways it does, but there are quality issues out there. And so now there's been a huge emphasis on quality since this time, but unfortunately, perhaps the methodology is better, but they've repeated looking at this in the last couple of years, and now they estimate the number is closer to 200,000. All right, so there are issues with quality, and if you're a healthcare management major, that's why we have a whole course just in quality. So this is an issue there. So back to the triple aim. So what we want to do is expand access to care. We want to keep costs affordable. And we know we've looked at this in this course a lot. There are definitely issues with cost of healthcare in our system. And we know that we're twice as expensive as any other industrialized nation. And we want to provide this high quality of care. And so there are issues surrounding that. We're still humans. A lot of these are accidental things, sometimes occurring in what we call the handoffs of things going from one person to another. And I could tell you many examples of reasons for this. Just a real quick one, worked in the blood bank for a while, and there was a patient named Mr. Smith in room 201, and he needed a blood transfusion. So by the time we got the blood ready and took it down there, they had transferred him out, but they actually put a woman in there named Mrs. Smith. So now we have Mrs. Smith in room 201, but these were two different people. Without closely examining, when you're in the doctor and they always ask you, what's your date of birth? What's this? What's that? This is why they're doing this. Because in this case, they're like, well, it's still a Smith, still this room. And so they gave Mrs. Smith Mr. Smith's blood, and she did have a transfusion reaction. Now, a major transfusion reaction could kill you. This was a minor one, so she just got hives and kind of like an allergic reaction, but it was not severe and she did recover. But it's just an illustration of how these kinds of things happen. So when you take a stress system, think of what's going on in the hospitals with COVID right now. A stressed system, stressed people, overworked people, accidents can happen. So cost, we have talked about this a lot, and so we've looked at all these different reasons of what it is about our system that is driving up costs. quality, here's just a definition of it, that individuals and populations get the outcomes we desire in a consistent and professional way. So when we talk about high quality care, though, are we saying the highest quality of care for everyone? Are we saying the most cost-effective care for the greatest number? So you can see there's a lot of different ways that we could look at this and interpret this. But in general, what we want is that people have access to services in an efficient manner, a cost-effective manner, and provided in an acceptable manner. When we look at quality, we can look at this in two different ways too. That one is what we call the micro view. And this is focuses on the individual, the care for the individual. We want technical quality. We do not want variation in how it's delivered, and we do not want medical errors. So that's kind of a clinical standpoint. But we also care about the person, and that the person gets the care in the way that they desire it and in the way they want it, in the setting that they want, etc. But the micro view focuses on the individual. It can also be looked at in terms of quality of life. The other way of looking at quality is the macro view. So this is kind of the greatest good for the greatest number of people. And, you know, an example of this would be vaccines. And we're certainly going to get there in the discussion over COVID vaccines. I just was reading a blog. We know that even with flu vaccines that people, I don't know, maybe half the population gets a flu shot. There is this debate out there, and I'm not going to get into the politics of this, but I was just reading it, and it was over vaccines. And so there are people saying, we need to develop the COVID vaccine. This is the only way that we're going to protect ourselves from a huge resurgence on this issue, to protect us from this coming back and decimating us in the fall. Okay, so that's what the scientists, epidemiologists, medical people are focusing on. There is a segment, and I'm not real clear of how large this segment is, but it's a substantial segment, who genuinely believes that COVID is manufactured. Bill Gates is behind this, and they want to scare us all to give us these vaccines because they're going to inject something in us that is going to control us in some way, and this is all a conspiracy for the deep state. If this was just a few people who genuinely believe this, I think it would be somewhat easy to dismiss. But I'm hearing neighbors say this. I am seeing a lot of people talk about this on blogs. And so here we go. So in terms of the macro view, there are some things that, looking at community-based health, that could take us to this herd immunity and maybe help us with something with the pandemic that would serve a greater good. But are we going to let individuals decide? Are we going to take a macro view? Or are we going to take a micro view? And so what do we need to get to herd immunity? Are we going to let people opt out? Are we going to hold them down and force them? All right. So this story that I'm sharing is something that's out there right now but kind of illustrates these two concepts and where we should go with this. And so as we've talked about in this class repeatedly of kind of the nature of our people, our believers in liberty and freedom, in the individual and rugged individualism, and all these very values that we spent a lot of time talking about at the beginning of this course are playing out in this very scenario that we're facing now. All right, so access is being able to get what you need in an affordable, convenient, acceptable, and effective manner. And so certainly timely as well. So what we're going to focus on, and you're going to do some work on this in your discussion, is what are the barriers to access? What are things that limit or impair people to getting what they need? So we're going to look at this, and so that we can understand it, hopefully remove or minimize them. Another thing that's going on with COVID, that it is revealing some things about the health status. I don't know whether it's about the delivery system, but certainly the health status. And so, for example, as we have studied with other diseases in this country, there are definitely disparities, and COVID is greatly, particularly COVID deaths, are greatly disproportionately affecting the African American community. So one of the things that we will look at is, what is that about? What is driving that? Is it socioeconomic? Is it health status? Is it access? All right. So there's a lot to be discovered about this. So what we're going to be doing, first I want you to think in terms of these 5 dimensions of access. And so geographic, physical, time, sociocultural, and financial. All right, so these are the 5 dimensions, and this is what you will use on that discussion page. So what do these mean? So geographic access, where the patient lives in relation to where service is provided. And so this is certainly true here in North Carolina. There are maps out there. There are counties that there is no hospital in that county. So there are concerns about access for that reason. And right now, particularly as relation to COVID. So it can be there's no provider, that patients don't have transportation. So the next one is physical access. And so that's being able to get in and move around and within the healthcare facility. And so certainly people that are need assisted devices or wheelchair bound would be an example. If you've ever gone to one of the big hospitals like Wake Baptist or Duke or Carolinas, you're parking in this remote parking lot and having to go through bridges and tunnels and etc. to get into these facilities. So that can be a challenge as well. So physical access can be an issue as well. And just even finding your way around the facility. So time is a big one too. So a good example of this would be mammograms. So years ago, we wanted more people to have mammograms at our facility. So we did some focus groups to find out why people weren't getting mammograms. And the responses were pretty clear. They're like, you're open 9 to 5, Monday through Friday. I work. How do you expect me to get a mammogram? I'm not going to take a day off of work to get a screening mammogram. So what we realized is that we needed to have evening hours and we had some Saturday hours. So those are just examples of how we need to offer services in a way that's timely for our patients. It can also be waiting a long time, and so in some other countries we've looked at, particularly elective services, people can wait a long time to get those services. Sociocultural is another access dimension. And this has to do with the beliefs, values, customs, or understandings that exist in healthcare. And COVID was a perfect example of that. I have seen it reported that there were some rumors or beliefs that African American people could not get COVID. And whether this has something to do as to why they're disproportionately affected with COVID remains to be seen when we are able to explore this in more detail afterward. There are people who believe that 5G technology causes COVID. And so these are just examples of current day thinking of just different belief systems that people have. As I mentioned, people believing that this is all manufactured by the deep state as a way of controlling us. But so we got to know where people are coming from. And in healthcare, so religious beliefs would be a perfect example too. And maybe they're about blood transfusions, maybe they're about organ donations. So there's different things like that. And so we have to understand where it is that people are coming from and work within their system of belief to be most effective in delivering care. Some of that can be language as well. And so if someone speaks only Spanish and comes into the emergency room, then we need an interpreter. There are really cool technology things that we've done now where we could use, they used to use telephones, but now they use computers and whatnot to do translations of, so that they can communicate in various languages. All right, so as you can imagine, money is a big one. And so COVID is another perfect example of this. They were wanting people to get tested. The cost of a COVID test varies greatly. I've heard anything from $35 to $2,500. I don't know. I don't quite understand what the cost actually is. But that's one of the things that our legislators tried to do, was to incorporate a way that that testing cost would not be a barrier for anyone to get testing. The next step was, well, what about treatments? So then some people were like, well, we need to make all COVID costs free. Well, and as we know in our system, many people are covered by insurance. And so it's like, why would we make it free when insurance would cover it? However, as we know, there's still deductibles and co-payments. So then the next step they tried to do is say, all right, we're going to minimize the out-of-pocket costs for people to get COVID treatment, because it's in society's best interest for everyone who has this to get tested and treated. And so one of the things I will point out, I'm hoping that you can follow what I'm discussing here, because this is what you've learned in this course. You are now prepared to understand and have these kinds of conversations because you know some fundamental things about how this system works. All right, so the money thing is a big thing. The next push on this is with COVID that's going to be kind of interesting is what we really need to know about the population at some point is not just who was sick, But what is the immunity in the population? And there is a way that they can measure this with a serology test, which basically measures your antibodies in your system, IgG in particular. And so they just, with a simple test of your blood, they can see if you produce the antibodies to COVID. And if you did, then the thinking is that you are then able to return to work, to play in sports. See, this is going to be very fascinating to see what happens with the COVID positive and non-COVID positive or COVID negative people, and what they're going to try to do with who gets to go back out into the world. So the best place you can be is to be COVID positive and have never been sick. All right. So that's going to be a next push, is to try to identify this. And I'm going to be the first one in line to get that. I want to know, was I exposed or not? You know, I've been indirectly exposed to 2 different people who tested positive. I have not been sick, but with spring allergies, who knows, you know? And so anyway, I just want to personally have this and go back to playing pickleball. But but to get this out there so that everybody can be tested, then it also has to be something that's paid for in some way. So we know that expensive services certainly are a barrier. Insurance doesn't reimburse for everything. And then certainly a huge barrier are people that don't have insurance. And then, as we said, that our collecting, our down payments, what we require, all that, our co-payments and deductibles are barriers. So this is something we've talked about in this class, that if you delay getting care when you need it, then you may be at a more severe stage. When you seek care, I just read a story, 30-year-old guy, he did have COVID symptoms. He did go to the emergency room. He did test positive, but they told him to go home. He didn't have severe enough symptoms to warrant being hospitalized, so they sent him home. And so he went home, and he got progressively worse over several days and started having the labored breathing. And so his wife, who also tested positive, was trying to watch him, take care of him, and so she checked on him about 2 a.m. He seemed to be doing better. He was getting some rest. She left him alone, and she found him dead the next morning at 6 a.m. So this is an extremely tragic story, but one of, you see this couple grappling with, you know, should we, the hospitals are jammed. The hospitals are a mess. Resources are thin. Should we wait? Should we go? And so it's kind of an example of, because of the situation in the emergency rooms, that people were delaying care. Now, conversely, excess care can also be a problem. So let's look at this. What iatrogenic or nosocomial infections. If you've got whatever, the flu, bad allergies, whatever's going on with you, and don't have COVID, you need to be really careful about going to an emergency room, because there are COVID positive people there. All right. So this is just an example of how inappropriately accessing care can also be dangerous. All right. But also it can be incorrect or ineffective therapies. Certainly there's a huge debate out there about this right now. Hydroxychloroquine would be a perfect example. Does it work? Does it not work? Should we try it? Should we invest a lot of money in it? Is it going to help people? Is it going to mislead people into thinking they're getting help when they really aren't getting help? All right. So this kind of, these are just examples of what we could be talking about here. And certainly the last one, and this would be the most controversial issue out there, of about the ventilators. Now, the situation that we're in this country, from what I can determine at the time I am recording this, it looks like we have enough ventilators. But I will tell you that I am keeping track of this, and hospitals around the United States, especially in the big urban areas, I was reading about one in Philadelphia, and what they've done is they have the attending physician will not make a decision of whether a patient gets a ventilator or not. There is a committee at that hospital that's made up of another physician, a nurse, and a hospital administrator. And they use a scoring mechanism based on your health status and a couple of other things. And with that score, they determine who will get the ventilator. All right, if it comes to that. Now, does this sound like something that we've never done before? No, we do it now with organ transplants. All right, so we don't want to waste any resources. So once again, we are trying to allocate resources in some ways, in some instances, with some things based on who can best be served by that. So once again, as we know, part of that the uninsured do not get the services they need as frequently or rapidly as people who are insured. All right, so this is why we want to get to universal coverage in some way. And so here's just some things. There's data. It is clear. People who are uninsured are much more likely to be diagnosed with cancer in later stages, delay things, less likely to get the surgery they need after heart attacks, and have higher mortalities. These will be things we'll be looking at as to why there are disparities in COVID. All right, so finally, last slide. What you're going to be doing in the discussion is a little bit different than this. But to get the points for the discussion on the triple aim, it's worth 50 points. You're going to list these 5 dimensions. And so what I want you to do, and this will be just particularly good if you do it in your own community, because we focused on that, and I like that focus. But give an example of, for each of these 5 dimensions, what is a barrier in your area? And then secondly, what is something that can be done to overcome this particular barrier on this dimension? All right, so that ends it for this. I hope you're having a good week.